Good afternoon, everyone. I have a question. Who here is a nurse? Stand up, please. Thank you. Now, you're probably saying, why did I do that? I'll tell you why I did that. Any of you have a parent, a spouse, a child, a BFF, a neighbor? You know what we all are? We're all patients. And unlike every other industry that is at this conference, the difference that makes is that healthcare is personal. And everything that you do, and everything that you do, and every single person you interact with and work with, and I know we have a doctor here in the room, what she does is personal, and it matters. And that's what we're going to talk about today. I'm Dr. Barry Chaikin. I'm the clinical lead at Tableau. My background is in general preventive medicine and public health. So I was a bit of a geek before there was the word geek. And my interest in my entire career has been on quality of care, patient safety, access to care, and operational efficiency. And hopefully we're going to discuss a little bit about that today. Matt?
Good afternoon, everyone. My name is Matt McWhorter with Tableau. Today I'm going to be the data doctor. I did not go to Harvard and get my MPH, but I have spent 8 years at Tableau. I know a thing or two about analytics. So Barry and I are going to tag team this session together. Barry asked me to do this session with him, and I got really excited about the possibilities. And I think we're going to have fun today. It's going to be an interactive, engaging session. And all of you are here for a reason, so thank you for taking the time. I know there's a lot of sessions that you could have chosen. Thank you for taking the time to be here today. My goal is for you to walk away feeling empowered to work with your clinicians, your physicians and nurses in your organizations to do things with data, to do good things with data. So with that, I'll turn it back to Barry to kick it off.
We're going to spend some time reviewing our session together, which you just heard a bit about. We're going to do a background. We're going to do an interactive session with all of you. So for those of you who have been to medical school, you know the Socratic method is very popular, which means that they call on you when you're least likely and available and ready to answer the question. I'm just warning all of you. You can all go back. The doors are locked, so you can't leave, okay? For those of you who are afraid and stuff. And we're going to actually build a dashboard together. Well, sort of, kind of. You know that's really not going to happen. But we're going to make believe that we're building a dashboard together, okay? And you're going to be involved in that. We're going to explore best practices in doing a dashboard. We are going to show you how we work together, which I think is really important. And then we're going to do about some suggestions about how you might work with clinicians going forward. Because I imagine, besides the four that I identified in the room, there are probably more clinicians around the world or in your organizations than are represented right here. So we're going to spend some time doing that. Next slide. So in 1987, I think this was, a friend of mine, colleague of mine, Larry Budnick, who's currently at Rutgers, a physician who also went to the same medical school I did, but we were in different classes, and I wrote a paper about the probability of your demise by the year 2000 from injuries. I'm very proud. It was like it's only twice I've been in the Journal of American Medical Association. I'm not a researcher, but it was kind of cool. I was young, and I got myself in JAMA, and what was really super excited, because I'm from New York. I read the New York Times all the time. It was an editorial in the New York Times that referenced our article. So I figured I had made it. I was just ready to retire because there was no way I was going to get any higher in my career. That was the pinnacle. That was the best. And to show you something, on the next slide, I'm going to show you the most fantastic visualizations you have ever seen in your entire life. This was state-of-the-art in the 1980s. I developed those, I think, from using a product called EPI-A that the CDC provided for free. And I want a round of applause for those visualizations because they are unbelievable, right? They put Tableau to shame, right? Matt, do they put Tableau to shame?
Drop the mic, Barry, drop the mic.
Clearly not. Next slide. So this slide was from 1990s, and I used this slide to do what? I was explaining the excitement I had in having transactional data. In this case, it would have been, wasn't from EMRs, because nobody really had EMRs back in those days, but it was basically ADT, admission discharge transfer system, to be able to do analytics. That amazing thing about analytics. I think I had a 386 processor I was able to get access to. You know, a lot faster than anything on your phone, I imagine. Okay, and I was able to do this and be able to do some analysis. Anybody know what that green thing up in the left, your right-hand corner up there is? Pointing to the red bar. Anyone know? Just raise your hand if you know what that is. Okay. How many of you don't know what it is and have never seen it in your entire life? All of the rest of you. Well, here's the gig. You know what that is? That's green bar. And what that meant is, and anytime you did analytics, you would actually print it out on that green bar, and somebody would sit there and flip the pages. Because we know human beings are phenomenal about rows and columns, correct? And we'd be able to understand exactly what that transactional grocery store essentially was telling us. Not. That was what we were thinking back in the 1990s. Next. Okay? Now we have all this other data that is now available to us to be able to do analytics. Amazing stuff. You know, back in that day, they didn't have if they had GPS satellites, none of us in the private sector were allowed to access. It was only for the military. Now they have all of this data that's available. Can you imagine me crunching this data on a 386 machine with those little beautiful bar graphs and stuff they weren't even bar graphs. They were like, whatever. What were they? They were ugly. That's what they were. Okay? And this is a really fantastically exciting time for us to be able to do things with data. Next slide. I want to explain two what I think is really important points for all of you to understand, because it's related to this journey we're going to take you on today. I have two types of analytics that you can do. The first is point analytics. Some of you might think of it as being ad hoc analytics. I got a problem, I want to understand what the problem is, and I go ahead and I do some analytics and figure out what the problem is. Very important, very useful. But reality is, it's a one-time deal. It's a one-time thing that you're looking at. Maybe you get a solution, maybe you do something about it, and you move on. Now, there are huge problems in doing point analytics if you don't combine it with, next slide, what I call surveillance analytics. What's surveillance analytics? Well, if my nurse colleagues, my doctor colleagues here, have a patient that they need to monitor their blood sugar on, or some other parameter, what good would it do for them to do analytics and find out their blood sugar's off on Tuesday? Doesn't it matter whether it's off on Monday or Wednesday or the following week or the following month or the following whatever? So they need some type of a tool to monitor that over time. And whether it's clinical or whether it's a janitor who's working in your hospital who cleans the OR suite, and they're responsible for doing a good job. Now, if there's a spike in surgical wound infections, you want the chief of surgery to know about it. You want the surgeons who are doing the procedures to know about it. But don't you want the janitor to know about it too? The janitor and the managers of those people who clean the room need to understand, is there something that I did wrong, we did wrong in our processes that are causing this problem? Did we change our disinfectant? Did we change our process in what we did? They know that process better than anyone else, better than the chief of surgery and better any of the surgeons. So for them to do their job effectively, they need to go ahead and see what's going on. Now, you don't want to give them a dashboard that has antibiotics on it, or even physicians' names. You just want to give them something. Here's what you use. Here's how it's gone over time. And I'm going to indicate to you that something may be out of normal, and that gets that individual janitor, or the managers of the janitors, the people who control the room. Everyone needs something, some information in a dashboard related to that issue. Because you can go ahead and spend a lot of time first doing the chief of surgery and then the surgeon and all of that, but you're not getting the full picture. So the concept is everyone in your organization has to get some data relevant to their role to be able to manage what they are doing. And that's the concept of surveillance analytics. Most of the time when you get to do surveillance analytics, you do absolutely nothing. But when you find out that something's a little off, you go ahead and investigate and figure out what in that process is causing that problem. Because remember one important point. People do not cause bad things to happen in the hospital, except in very rare exceptions. It is the processes that are bad and broken down that cause that bad outcome on a continual basis. And on top of that, kudos to the doctors, the nurses, the therapists, the ward clerks, and everyone else who works in a provider organization who figures out how to get around those bad processes to allow people to walk out of the hospital healthy. They do a magical, amazing thing. So what our obligation today is, what all of our obligation today is to go ahead and figure out how do we make it such that those people don't have to worry about overcoming those bad processes, but we give them the tools and the methodology and the information to be able to identify when they're not working and have them a way to correct them and make them work better. Next slide. This is so important, particularly in this crazy age of divisiveness in our country, but we're in healthcare, and in healthcare, facts matter. And when you get facts that are telling you in a surveillance dashboard that something's not working, then you have to figure out, I got to change what I'm doing. You don't stick to it because that's what you always do. So put all the political and all the craziness that's happening outside this door. Remember your healthcare people. When the facts change, I change my mind. What do you do, doctor? What do you do, nurse? What do you do, administrator, when you get new facts? And your job is to create dashboards that give them those facts they can react to.
All right, so this is the audience participation section of the presentation. What Barry did was basically tee up why is point analytics, why is surveillance analytics, why is analytics on clinical data so important. And what we've done in today's session is introduce a clinical data set. So we're, as a group, going to be working with a clinical data set and soliciting feedback from the audience. So how many in the room today build visualizations from scratch? How many would you say are visitors, to use the term? Okay, so maybe about half the room. How many of you are just consumers of the information? You're just purely consumers. You're not necessarily doing the analysis on your own. Handful. How many are interested in learning more and want to dive in today and are new to Tableau? A few hands? Awesome. Well, I'm glad all of you are here. I think you're going to, each and every one of you will get something out of today's session. So the exercise, again, we ask for your participation, is think about how you're going to tell a story with data. That's always the key objective, whether you're working with point analytics or surveillance analytics. How does it speak to the audience? Who is the audience? And what's the responsibility of us as dashboard authors or Viz authors to tell that story objectively and not to skew it with cognitive bias or selection bias? So we'll talk through that. I'm going to have Barry introduce the data set from a medical standpoint. Go for it, Barry.
Thanks, Matt. So before we start, I just want to say, Matt's a data doctor. He really is. And guess what I'm not? I am not a data doctor, all right? I'm good, I have 10 fingers and 10 toes, so I can at least can count to 20. But I am not a data doctor. And what happened, we did a journey together. And I want you to learn from our journey, to share what we did together, because he was a data doctor, and I'm just a medical doctor. So I understood this data set and what it may mean, but I surely didn't understand how to tell the story from it. Surely did not understand how to tell the story around in using visualizations. Matt, on the other hand, he knew everything about how to show visualizations and tell a story, but he didn't know what ischemic, stroke was. No idea. Didn't know the difference between that and hemorrhagic stroke. Had no clue. I'm sure he Googled it. He probably still didn't understand it. He didn't know what it meant to have bleeding outside of the head. What does that mean? He didn't know what aspirin did. He didn't know what heparin did. He didn't know any of these things. But he sure knew a lot about how to tell the story. So what we did is the two of us went on this very meaningful, I believe for the both of us, journey together to look at this data set and build these dashboards that you're going to help us go through today. And why is it important for us to tell you that story? The reason is that in your organization, you don't have dozens, you don't have hundreds, you have thousands of people like me who know absolutely little, in some cases nothing, about building a visualization to tell a story. We know a lot about cardiac care, diabetes, cancer, tons, endless amounts, but we couldn't ever tell you the story. And I'll give you proof of that. You see that little diagram there? That's the story that was in the journal article. Now, I understand it's the 1990s, late 1990s, it didn't have, Tableau, but it didn't even have my bar graph. It was nothing there to tell a story. We worked to be able to obtain a clinical data set, and they're very, very difficult to obtain because of the unidentified and stuff. So what we did is we decided we were going to choose a publicly available data set. It has a surprise in it. I'm going to save that for later. A publicly available data set that addressed ischemic stroke. And it was done internationally, as you see, 35 countries, 466 hospitals. And it was a randomized trial that looked at what was the outcome. Did people die within 14 days or within 60 days after receiving nothing, after receiving 2 different doses of heparin, or receiving some aspirin? For those of you clinicians in the room, you know we don't do this anymore. This is from 20 years ago. We have TPA and other things that are much more effective. The golden hour, I can talk a little bit about that in a minute. But this is what was done today at the time, and we wanted to go ahead and see who died, who helped, and what the information was. Next slide. That's the results. Can anybody tell me the result real quick? What's the result? How many patients? What worked? What didn't? Isn't that the most amazing graph you've ever seen in your life? Who doesn't love rows and columns? They are the best thing in the whole world, aren't they? It says so much. No, it doesn't. It'll take you how long to figure out what this says? Long time. What?
A day.
A day, at least a day. You know what? Matt and I were looking at this chart, and we were debating what it meant. And then we had to go in and read the actual Lancet article to figure out what it really meant. And then we still were debating what it really meant, and we had to go online and look up a whole bunch of words in Google to try to understand the English about what it meant. So by that time, how many patients would die from stroke? A lot. How much patient care would not change in the time it took everybody to figure out what they were telling to tell us in the first place? Amazing stuff, right? So this is what this chart tells us. What we did is we took all of those numbers, all of that stuff, and we're going to work with you to tell a story.
All right, so let's jump into it. I realize you're all getting this in real time, so I'm going to try to take it slow and walk you through what data we have as part of this stroke trial. As Barry mentioned, it was conducted in the early 90s, 91 to 95. It was 35 countries, 466 hospitals, 19,000 patients. It was the biggest stroke trial ever conducted, and the findings were significant. Now we've changed the way we treat strokes. So there's a lot of data elements that got captured out of that study. Things like what happened after the first 14 days that a patient was admitted to the hospital. What kind of stroke did they have? When they got discharged, were they dependent on others for day-to-day activities? When did it happen from a timing standpoint? Everything down to the date, to the hour of the day of the week. Did they have a recurrent stroke? So that initial stroke got them in the study. Did they have a recurrent stroke? And it could have been ischemic or hemorrhagic. I learned how to pronounce those words for this session. And then what treatments were done to them in those first 14 days? Right? Were they given heparin? Were they given aspirin? Right? That's really what this study was about, is how do we treat these strokes? Or do we give nothing? And they randomized that such that it provided a good study. So not a lot of measures, or a lot of dimensions, but not a lot of measures in this data set. What they did, though, was predict the probability of death or dependence, or at 6 months and 14 days, depending on the severity of the stroke. So they looked at it and did a CT scan or diagnosed how severe was that stroke and what's the probability of death as a result. So we can look at that from a measure standpoint, but the main one is just the number of people. How many people, how many patients fell into each of these categories? Who was treated with heparin, who was treated with aspirin, and so on. So in order to build this story out, I like to think of it in simple terms. And we as a group all need to understand the who, what, why, where, how, and when. So I want to go through a few of those questions to start. And I solicit your feedback from the audience. What are some of the best ways, knowing now what we're working with in the data set, what are some of the best ways to answer the who?
That has nothing to do with the band. That was a question. Come on. I'm in the audience. I'm not going to talk the whole time. We got to hear from you. Ask the question again, because they probably
So the who, what, why, where, when, and how. What is the best way to answer the who? Given the dimensions we got, how would we describe the patients in this study? What are some characteristics about the patients?
Here we go.
Prescribed treatment?
Age, sex, good.
What else? Geographic location. Come on, scream it out. Come on, you're Tableau people. You're supposed to be loud and all that stuff.
Use your outside voice.
Comorbidity. No, mode of arrival. Type of stroke. Come on. Diagnosis. We have clinical people in the room. We can always call on the nurses. I couldn't hear you. Ethnicity. Country of origin. Think all of these things are important? Drugs.
Drugs, yep.
Heparin, non-heparin.
So we got a lot of good input there. Sex is a field in the data set. We'll start there. So you can see, not too surprising, but there were more males in the study than females, 10,000 to 9,000. And the other one that I heard is age. So why don't we go ahead and look at age, and that's another field we have to work with. And we can look at the raw age. When I started doing this with Barry, he said, why don't you group it? And you'll see that by the different ages, how many we had in each of these groups. So you can see it really starts to pick up. Let me zoom in for you.
So as you get older, you're at a higher risk of stroke. Want to know that? You kind of knew that, right? But what would you want to know the difference between men and women? Might matter. You notice he categorized them into different age categories. Why do we do that? We do that because if you're an epidemiologist, right, you want to group them into buckets because a 71-year-old isn't that much different than a 72-year-old, but a 71-year-old is very different than a 41-year-old. So you go ahead and do that. We try to follow the way you typically would report this in public health. So that's how we created those different buckets. But again, about the journey, Matt didn't know about that. He didn't know how he did it. And when he first did it, he did it basically, for example, he would do 50 to 55, right? Instead of 50 to 54, right? Or he would do 50 to 50, the conventions and the buckets he created weren't consistent with what you would normally see. And then we discussed and we decided this is the way we wanted to show our data, starting at the 0 and going to 4 instead of the other way around. We're feeling it would be more meaningful.
So you can see where the data peaks in age. Now we know how many males and females. We now know what age the patient was at the initial stroke. And keep in mind, they did the initial randomization and admitted them to the trial, and then they monitored them over a 6-month period. So they captured this age at that initial encounter. There was another WHO question that somebody posed, which I liked, and that was geography. So we happen to have country in this data set. We'll just double click that. We'll look at where the patients were concentrated. So you can see it was a global study. We mentioned the 36 countries. Let's take a peek at where the most came from. So it looks like the UK, followed by Italy, and then Switzerland. In the US, there only happened to be 131 out of the 19,000 that were in the study. So this study originated out of Oxford. Makes sense that most would be in the UK. So now we've got the where. So now we know a little bit about who. In terms of what happened and what their condition was when they got admitted and what was the outcome, I'd like to look at some of the things like, what was the stroke? What was the ultimate outcome at that 6-month checkup, right? So we have things like cause of death at the 14-day mark, cause of death at the 6-month mark. Let's take a look at how the study breaks down by the outcomes. So we can see that most were survivors. I'll just fit this for you. So you can see out of the 19,000, 14,000 were alive after that 6-month checkup. 1,400 resulted in another cause of death. And then if they had another cause of death after the 14 days, there was 800 in that bucket. But really what this study wanted to look at is that stroke and what was the impact of the medication or no medication on the stroke.
What do we know so far? What have we discovered so far? Out of that chart, remember that nice, beautiful chart that we couldn't understand for at least a day? What do we know about that chart now? Come on, tell me. Most people are survivors. What else do we know? Higher male population. What else do we know? Mostly European. Why would it be mostly European? Besides him saying that, what does that mean that it was mostly European? Selection bias. right? Right? A lot of people and a lot of institutions in the US just didn't enroll in this providing the data. So always pay attention to that, right? As you do stuff, worry about that selection bias. So it's giving us an idea, most people didn't die of stroke and all this other stuff, but we have no idea. What two things don't we know? Several things we don't know. What two specific things we don't know, or three specific things we don't know? What'd the aspirin do? It's in the chart. Didn't anybody read the chart? The chart said what's in it. Come on. Okay, what else do we not know about the effect of heparin, right? You didn't read the chart on that either? What's going on in this group? All right, so we don't know about the heparin, we don't know about the aspirin, right? Okay, well, let's kind of figure it out. And I bet you at the end we can do a story that's going to be a lot faster than reading that chart. One day, Matt, we got to beat one day today. And we only have about 27 minutes to do it.
I think we can make it.
All right.
So here's the dosage or treatment by number of patients. So you can see whether they were given aspirin or heparin, and then whether it was a high dose of heparin or a low dose of heparin. So those are really the buckets, the last one being no medicine at all. So they split it up pretty evenly, as you can see. If you were to break it down by heparin, no heparin, it's an even split. Aspirin, no aspirin, it's an even split of those 19,000 patients. So now we know some of the treatments that were done. I want to go back to the WHO for a minute. Who thinks there's a correlation between age and the stroke? We already saw that how many patients were admitted by their age, right? Much more later in their 70s than early. In fact, we didn't start it until the 40 age mark. There's a correlation there. Who thinks there's a correlation in male versus female? We know we have more males in the study, but in terms of when in their age did it happen to males versus females? And could we investigate that question? What do you think, Barry? Is there a correlation between age and sex?
I don't know. I didn't look at the data. There are a lot smart people in this room. What do they think? Come on, I want to hear from non-clinical people because you make up the large majority. Unless you want me to call on you. Yes. Yes, what? Yes, sir. Yes, sir. Yes. Yes, sir.
Yes,
what?
sir.
I think it'll make a difference between male and female. Think it'll make a difference between male and female.
So let's explore that. We have age now plotted. I just want to do a circle now because I want to break this out by the different sexes. So we can see, this is absolute numbers, but we'll be able to see males versus females. So by the absolute number, yes, certainly males start earlier with 50, 55, 60, it starts to separate. 65, it peaks at 70 to 74. Females, on the other hand, peak at 80 to 84. It's probably the only thing men are early on in life is this chart. So how do we look now at how were they treated, right? Or what is the outcome given these age groups? Now, this is absolute numbers. We might want to look at this instead as a percentage because there were more males than females. It's going to skew. So I can throw on a percent of total calculation. Now, this is just percent of that. This isn't exactly what we want because it just took the absolute number. But if we compute it by the age, now we've got comparative circles. So in other words, 20% of females in our entire female population were 80 to 84 when they had an initial stroke.
So Matt, when you were doing this, when we were working together on this, when you first saw the data set, what were you first thinking of looking at the data this way, and how did that change after we talked a little bit?
Yeah, so my initial approach was to answer some of those basic diagnostic questions. Who, where, what, when, why. And then as I started to look at the data, I had questions like, Barry, what is the difference between that initial and the recurrent stroke? Why is that significant? Why is it significant to give more or less heparin? Why would they not give any drugs to some of the patients? So as we started to converse about it, Barry gave me insight to the types of strokes, what causes them, how they're treated, and then I was able to factor that in, going with a little more educated approach to looking at this data. And I think that really developed the conversation. That's how it started, but it was all about that curiosity. And as Barry said, I did some Googling to understand the terminology in the data set. There's quite a bit in there that didn't make sense to me initially.
So before we go further, I just want to ask a question of all of you. How many of you worked in a similar situation and found that your communication with that other person that you were working with seemed to be a bit off because they were saying things to you that you didn't understand, and you were saying things to them that it seemed they didn't understand?
I would give an example of it.
Yeah, come on.
Okay. So my background is an engineer, and I work in a finance department automating a lot of accounting protocols. And sometimes when working with the accountants, they've had the same data in Excel for forever. And so they want 30 different sheets of cuts of data, but they don't really know what they want in there. And so one of the things we're looking at is the 50 most expensive things that we pay for Aetna for insurance. And what we're finding is that there's certain areas where the most expensive thing could be something like in New Mexico, ambulances are being called all the time for people that need glasses or people that need contacts because there's not really like a service in the area for them to get a ride to the doctor. Whereas in another region, it may be something different, but they didn't know how they wanted to see that. And so they go, oh, I just want the charts, I want that. So we had to sit down and kind of do it like this. And I finally said, here's what I'll do. I'll make a bunch of graphs and charts. I don't know what's important. You look at it, you get 3 dimensions, pick what's on it. We'll make a ton of visualizations. You can watch some videos online and then come back and tell me. And so I gave them the 3 months, and I got kind of worried that they weren't going to come back with anything, that they got overwhelmed. And then a couple weeks ago, we sat down, they had about 20 people on the call, and they're like, how do we learn how to use Tableau? This is great. Like, we want this dimension, this color, this shape. We want this type of chart, this type of chart, and this type of chart. And they're like, now we won't have to spend 40 hours a month going through all these different sheets to figure out how we need to change our different groupings in insurance. We can just have a dashboard that tells us the top ones, communicate that to whoever runs Medicare, and they can work on it for the next year. Yeah.
Unbelievable. Did I pay you anything to say that?
No.
Okay, I just want to make sure everybody knew. Anyone else have a quick story? That was a great one. Financial in healthcare, right? And you have a clinical one? You have a good story? Oh, great.
So this is, too bad you don't have your surveillance slide up because it was actually, I believe that was a CAUTI that you showed, a catheter-associated UTI, for those non-clinical folks, such as myself. My background's computer science. I worked for a hospital system at one point in my career, and they were like, well, we want to just put this data of how many CAUTIs we get in this hospital on an Excel sheet. And this kind of tied into Medicare data because Medicare started reimbursing less for hospitals that had more CAUTIs.
Everybody got that? You understand? Okay, good.
Yeah, sorry. Yeah, basically, it came down to it. I did a line chart in Excel, and finally, Tableau was new, downloaded it, tried it out, and the woman that was in charge of the IP, she was just like, you know what? There is a benchmark. Why can't we show benchmarks? Why can't we show, like, it's just line graph after line graph, and I'm sick of it. And so with Tableau, we were able to put in conditional formatting of, like, when the hospital over time was below or above their benchmark, and just used conditional formatting to just kind of let clinicians know where they were, if they were red or green, and we did it for all of the healthcare-acquired infections throughout the hospital. I have no idea, I'm not the clinician. I know that we definitely prevented some infections, at least maybe about 20 a year.
Not bad. Maybe you saved a life, right?
Yeah.
You don't know. Great. Go ahead, Matt. Take us in the journey.
All right, so we're getting there. We're starting to understand the data better, at least the basic facts. But what we want to get into now is to look at some of the correlation between what the outcome was and what the treatment prescribed was. So I'll break it out again by patient sex. And this time, I don't necessarily want to see the absolute numbers because I want to be able to make a like-to-like comparison. So I'm going to, again, do the table calc that will normalize these. I want to compute this down. So now we've got 100% for each. This raw number is still behind the scenes. So I'll throw that there. We can see. Now when we put this together, I want to be able to look at that age chart with the outcomes and the sex. So we'll bring in the patient sex. We'll bring in their treatment. We'll bring in their condition. We're also going to look at the age, so we'll bring that down to the bottom. So ultimately, we want to make this interactive, and where I can click on any of these visualizations and slice the data and look at, again, the relationship between the different dimensions. So now we've got males and females here. I'm going to color code this so it matches the chart, the age chart. We want to also look at, as we pick on these different conditions, now what percent of the population, be it male, female, or by age, were impacted that way. So to do that, I don't know if you're familiar with them, we have set actions. Set actions will allow us to basically brush within the data set how many were in that population without getting rid of the entire bar, and I'll show you what I mean. So let's do an action here, a set action. Change the set values is what we want to do. We want to be able to click on the patient condition and impact our outcome at 14 days and 6 months. So now we can see of the males and females, there's not a lot of difference. The blue being the ones in the set. So in the set in this case would be those that were alive at 14 days and those that were alive at 6 months. Everybody with me? I clicked on that. But if we wanted to look at how many fell victim to that initial stroke, now we see it's 3.19 and 2.18, slightly more females than males. I'm going to do one thing here because we're not interested in other cause of death. I'm going to exclude that from both 14 days and 6 months. I'm also going to, just so we have bigger numbers to work with, I'm going to exclude those that were reported alive at 6 months. So now we're just trying to understand the stroke data here. Now I'm going to apply that filter over to our other data set as well, or other sheet, excuse me. So make that there. Okay, so now we have a much better view of how many were ultimately died of the initial stroke at 6 months, are in the blue. And there's not a lot of difference between sex and outcome. There's not a lot of correlation there. Possibly with recurrent stroke, we can see that 14% more males had recurrent stroke that resulted in death. With females, they're about like and like, but it was slightly more females that died of that initial stroke. So that's kind of step one. The other thing I might want to do is look at the age correlation. So we can use this filter. We'll just add a filter to change our chart at the bottom. And there we have it. So now we can see, again, because these are comparative dots, from that someone who was alive at 14 days, but at 6 months had died of that initial stroke. We can see male versus female. It actually happens a lot more with males at that 65 to 69 range than it does with females. So now we get the age data correlation as well. So now we have a really good handle on the WHO and the different demographics. I don't have any more demographic fields other than their location, but we now know by sex and by age and outcome what ultimately happened. I want to look at some of the treatment groups now. Anybody have questions on what we just looked at, or what we just did? Or maybe input a different way to look at it?
Now, tell me about that aspirin and heparin thing.
Yeah, let's get into that.
Let's get into the good stuff.
All right, so I showed you this before, the treatment groups. Let me just start with that for sake of time. And I want to break it down by what was the treatment and then what was the outcome. So ultimately, if we're going to use this as our treatment group, I want to look at the cause of death at 14 days and cause of death at 6 months. So I've done some grouping on this. I'm going to again normalize this so that we can see percentage-wise how people break down. So the blues are those that survived. Okay, so you can see here's the different causes of death, the outcomes, whether it be other cause of death, recurrent stroke, initial stroke, and then the blue are those that are alive. Now that's at 14 days. So right away we're starting to see that survival rate, if you're using the blue as a survival rate, it didn't change much across those treatment groups.
So if you were going to have a stroke, right? Hopefully none of you do. If you were going to have a stroke, how many want to be given heparin? Anybody? You got one person. Two. How many people want to be given aspirin? 3, 4, 5. How many people want to be given heparin and aspirin? Okay. How many people think it doesn't make a goddamn difference? Thank you very much. It does not make a difference. How many of you do not know about heparin? Do you know about what heparin is? Right? Right? Blood thinner, right. It's a blood thinner. What does a blood thinner do?
Well, if you cut yourself, you'll just keep bleeding.
If you cut yourself, you keep bleeding. So what happens if they give you heparin? Right? It prevents blood clot. Well, maybe, right? Could. But you keep bleeding, right? So here's a tough question for you. You have a stroke, and you have a choice of getting heparin or not. If you get the heparin, it does nothing for you. But if you get the heparin, you have a risk of bleeding somewhere else. Maybe dying from the bleed. Maybe bleeding into your head, your little coconut thing here, and dying from that. So again, I'm going to ask the question, how many people want heparin? Nobody. Now, let me ask you another question, because you said it was going to take a day. When you saw that chart, did you know that?
No, but it was ugly.
No, she says. Did anybody else know that? You looked at the chart. I gave it to you. You had at least 2 or 3 minutes to look at it. All right? How many minutes did it take you to figure that out over here? Not really very long, did it? Right? A lot better than that chart. Okay? Keep going, Matt.
All right, so we want to put this together in a single view and look and see if there's any kind of time element to this. So we looked at each of those treatment groups. Bear with me. 14 days and 6 months. We can see over 6 months that the survival is lower. So you see the 76% there. That's not surprising, but the 6-month checkup. But there is a time element to this. Keep in mind this study was done over 6 years. Each patient was 6 months. So we'd want to look at the date that the patient was randomized. I want to use the page shelf in this case because it's going to show it to us by year. And I want to do that for both 14 days and 6 months. So now as I do this, you'll see how the two play together. And if there's any kind of deviation from year to year, it'll stick out. So we can see that there's 1 year where that initial stroke was a larger cause. So you can see at the top of that, it's 1991 data. So in order to tell this story, one of the things we want to look at is, well, how did those patients flow in what time period? Why did 1991 stick out there? Maybe it's a small sample size. So one question we forgot to answer to make the story complete is that date of randomization and how many patients came in a given year.
And what would you expect when you start a study? What's the most difficult part when you start doing a study? That's obviously at the beginning, in enrolling patients, in enrolling facilities, in getting everybody up to speed in protocols, how to collect the data, all that other stuff. I would guess that all of this data was collected by hand back in the day because they hadn't invented the mobile phone yet. Well, they did, but it wasn't what we have here. So it was clearly all done. And as you can see, time goes on, you get more people, higher enrollment, all that good stuff. The study starts to get a bit of momentum. So as Matt's about to go and show you the whole story, okay? And as he puts that slide up, that I wanted to tell you one thing. We spend a lot of time in medicine and medical research identifying things, discovery. We discover new things. All of the papers that you, not all, a huge majority of the papers that are written in the medical literature talk about A causing B or A being related to B. They're a positive study, as we call them. Why is that the case? For a variety of reasons. If it's funded by pharmaceutical companies or research companies, life science companies, obviously they want the study to be positive that enhances whatever drug they have and stuff like that. There's a second reason that happens, okay? And none of this is nefarious. Don't take this as being ragging on pharmaceutical companies or ragging on life sciences companies. This is the human condition. None of us want to do something that produces no results, right? But even in academia, one of the things that you're rewarded for is your ability to take a data set and publish papers. Nobody really likes publishing papers that's showing no results. It's just not the way we're wired, and that's what we do. So a lot of the times you'll see studies that are always positive, 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 positive. And that's okay. That's how we move medical science along. We need to do multiple studies to understand what works. What was really phenomenal about this study is that it shows what? Nothing worked. How great is that? This study is phenomenal and needs you to reset your thinking about working with your professional colleagues, your clinical colleagues, and understanding that you're really, not only are you not most of the time, almost all the time for you, not doing clinical research. You're focused on trying to understand what's happening in the processes in your organization. And if you go back to my surveillance point, surveillance analytics, in a lot of ways you want to discover that nothing's happening and it's all working fine. So we thought there was a great way to give you that message of, one, if you're doing clinical research, it's okay to find that things are not working, having a negative study, and this one was a pretty big one. And the second thing is it's a really foundation for what you might do in doing surveillance analytics and manager processes, whether it's the CEO looking at performance metrics around financial and some outcomes, to the people who are working on the nursing wards, who looked at our doctors and nurses looking at outcomes related to different things they do on that ward, infection rates, CAUTI, what have you, to whether the janitors are being efficient in cleaning the surgical suite. And the reality is, it's your job, it's still your job to work with your clinical people, work with your subject matter experts, even clinical, non-clinical, financial, what have you. We heard a story about that earlier from you about how to do that. And that's your job. Develop that communication and make it happen. Quick, show them that the wonderful story dashboard you have.
Yeah, so remember we wanted to build a story together, and we didn't get through all the different visuals, but if it's on us to be able to tell that story objectively and do it with data and do it with visualizations, I could go read the Lancet article that Barry shared with me when we started this journey, but I'd much rather dig into the data and analyze it to understand it. And ultimately, you're going to need to make it digestible for others. So how do you convey what the study found in a visual way? And these are just some ideas. But we went through and understood the who and how many by sex and what their treatment was and when they were admitted to the study. We know that it was a study over all those countries and all those hospitals. We also know that by age group, there were some correlations in what that outcome was, and not necessarily by sex, but by age group, certainly, age and sex, there's a correlation there. When we look at the survival rates, there wasn't too much difference between those that were treated with aspirin and heparin, and this is ultimately what the study showed, or no drugs at all. And then when we get into just very simply, ignore the dose on heparin, did they have heparin or not? Did they have aspirin or not? We can see that survival rates were consistent there. No statistically significant difference. But then the study also found, and this is a visual way to show what if you were to read through the paragraphs, that there were some interesting findings. For example, if someone was given heparin, they had significantly fewer recurrent ischemic strokes, okay, because their blood was thinner, they didn't have a recurrent stroke. Yet they had significantly more recurrent hemorrhagic strokes. So it kind of offset itself in that they would just have a different type of stroke if they were given heparin. Also, it was associated to significant non-cerebral extracranial bleeds, heparin was. So you can see the heparin and no heparin here. And then if you just sum up all the bad things that could happen, whether it was death or non-cerebral bleeds, heparin did in fact cause more of that if you had it than if you did not. Now over 6 months though, there wasn't really a difference between the heparin and no heparin in that 6-month follow-up. Now same for aspirin. Did you want to say something there, Barry?
I was just going to say that was a way to tell this wonderful story. I have a request. I want 5 more minutes of your time. Is that okay? All right, because I'm very stickler about starting and ending on time, and I hate to be late. So if any of you need to go, feel free to go. But I'd like just 5 more minutes of your time because there's an important message I'd like to finish up with. So, and thank you so much for indulging me, and I apologize for inconveniencing you like this. Can we go to the slides, Matt?
Yep.
Just to finish up. Well, we talked about the interactive session, right? And next one. Next one. You know, if you find some time, you just might find you get what you need. Okay, and this is on the Tableau Public. Next slide. Because of that slide, a PhD epidemiologist doing genetic research at the National Institute of Health created this slide, which basically helps her understand how genes express themselves. And she never would have thought of that if it wasn't for that slide. Next slide, we've actually gone through all of this in this interaction, so we moved it along. As you imagine, when you start to create these visualizations on the fly like we were doing, it's a little tough. But I wanted to share this Steve Jobs quote. You can read it yourself, but the bottom line is you have to communicate with those subject matter experts to understand what they actually need, okay? So, because they don't know what you can do for them. They have no idea what the end result's going to be unless you work with them and figure it out. Because I always would tell the story, if I want to go from Boston to New York and I didn't know that they had a plane that flies there, the only ways I think of going was by bicycle, by walking, by driving, and 47 hours on an Amtrak train, if you know what I'm talking about. Okay? Next slide. In about a half hour or so, there's going to be a presentation done by a young biostatistician named Nadia Chung from the City of Hope. And she's going to show some of these slides. I wanted to do an advertisement for her session. And she's going to talk about how she's used visualizations at City of Hope, California Teacher Study, that's done the major research and the major database that helps to discover the causes and relationships around women's cancers. So I encourage you to do that, and it's in Breakers H as the next session. This is another one of the visualizations that she's done. The next visualization is around work done on ACOs, accountable care organizations, done by one of our customers. You can see this is very useful for them. They distribute that data. They're monitoring quality metrics across the board. They use colors, they use boxes, they use wording. They can drill down. It's all there as a surveillance tool to tell a story. Next slide. Another example of those quality metrics that are important to them. If any of you go to the Healthcare Data Cabana and you're interested in quality metrics, ask for a young man named Derek Sear. He is our expert in quality metrics. And if he can't, and outcomes metrics, and if he can't answer the question, you're not asking the right question, because he knows everything about that. I encourage you to spend some time with Derek. He's a fantastic resource. This is some other metrics that have also been available that you can look at and how they use them for dashboards for kidney dialysis. When a patient's ready to move from kidney dialysis to transplant, and they monitor how their kidney function works, and when they get to a certain point, they know it's time. We need to start to prepare them, transition them, get them on the list, make it so that we're treating them the right way. And then let's the next one. I talked a lot about communication, and I'm going to need some help from my nurse over here in the audience. If you can come with me for a second. Everyone loves to hear a story, right? So make sure you tell a story. Can I have the next slide? Thank you. Can you come with me for a minute? Thank you. Come with me. All right? And you're going to step on the stage.
You didn't know you'd be doing this.
And what that means is healthcare is personal. And you have to have that hug between yourself as a data analyst and anybody who's in clinical. So you give them the hug. You always give a nurse a hug. You always give a doctor a hug. You always give a therapist a hug. But you know what? Every one of you is a caregiver. And if I could, I'd give you all a hug. Because what you do every day and what you're going to do after you leave here and work with those clinical people is design dashboards that every single day are going to save someone's life. Because that's why you're here and that's why you're in healthcare. Thank you so much for coming. Have a great conference. It was great to spend some time with you today.